Hello and welcome. My name is Liz Bowley, and I am the Director of Education and Technical Assistance at the New Hampshire Harm Reduction Coalition. I have lived experience in recovery and substance use. And today we're going to be talking about Harm Reduction 102 and a naloxone update. So without further ado, we will get started. All right, so our learning objectives for this presentation are going to be as follows. We are looking to increase an understanding of drug trends on a local and national level and how this relates to overdose prevention. We're going to distinguish between intoxication and respiratory depression and decide when it's appropriate to administer naloxone. And we're going to define how drug misinformation impacts the lives of people who use drugs in New Hampshire and the world. For our agenda, we're going to start off with people who use drugs or people first, go into some more details about each substance, the basics, and then we're going to go into our naloxone update. Just for clarity's sake, we have a glossary here that we'll go over. So you will hear me say these acronyms throughout the entire presentation. Um, so when you're able to look over the slides, just know that this is what I'm talking about. So if I say an SSP, that's a syringe service program like we run across the state of New Hampshire. SUD stands for substance use disorder. MAT, which we'll talk a little bit more about detailed along with MOUD and OAT, but MAT is medication assisted treatment. A lot of folks prefer, a lot of folks who are engaged in medication assisted treatment prefer MAT as the language because that's the language they understand. There has been a push lately to use the term MOUD, which is medication for opioid use disorder, or OAT, which is opioid agonist treatment. Um, but when we're speaking specifically about populations of folks who use drugs, it's important to use the language that they already understand. When we change the language on them constantly, it really disconnects them from their care, and they're really not able to understand what they're wanting to access. When you say something like MAT to a participant, they know exactly what that is. So just things to be aware of. Some people prefer MOUD, some people prefer OAT. It's all up to what you prefer and what you understand. Um, P PWUD is people who use drugs. You'll hear that and see that throughout the entire presentation, although you'll notice every single time I'm saying people who use drugs because that is the most important part of the sentence is we're putting the people first, instead of kind of squishing it all together and saying something like PUD, uh, which to me sounds a little nonsensical. People who inject drugs is the same thing. It's just another way to refer to folks when they are specifically injection drug users. NIMBY is a term that some drug activists use for people who are very resistant to having harm reduction programs in their area. Or even folks who use drugs, unhoused folks. So it stands for not in my backyard. And basically what that means is it's folks who maybe just don't understand the stigma that folks who use drugs are facing. So they don't want programs like syringe exchanges, MAT programs in their backyard because they believe that it brings more folks to it and it creates more crime and drug use. But as we'll learn, the evidence shows that that's actually opposite. OPC is an overdose prevention center. Now, we don't have any in the state of New Hampshire, But in Canada and across the United States, there are overdose prevention centers, and that is something that you might have heard of, also called a supervised consumption site. But overdose prevention center is really the term that we like to use because what's happening is when harm reductionists are in those spaces, is they really are preventing the overdoses from happening because they're able to intervene directly after someone is using a substance. Um, and lastly, when we're talking about drug checking specifically, we are not talking about urinary analysis tests when someone is either going in or out of treatment or working with law enforcement. We're talking about checking your drugs with various kinds of machinery, whether it be fentanyl test strips, xylazine test strips, and these are immunoassay test strips that have been used as UA test strips in the past, but now they're currently used by a lot of different programs to test if your supply has one of these adulterants in it so you can proceed with caution. There are bigger drug checking programs around the United States that have things called FTRI machines, which are like intensive analysis that gets down to like 5% of what is in the supply. So when we're saying drug checking, we are testing drugs prior to consumption so that we have the knowledge about what is in our unregulated drug supply so we can proceed with caution. You'll hear me say a whole bunch of other things this presentation, but this is most of the acronyms that we'll be going through. So let us get started. Um, So importantly, people who use drugs, what does it mean? People who use drugs. It's only shorthand. And as I was saying before, it's so important to say the whole sentence. Some people will shorthand it just because it's easier to write or it putting in reports, and that's totally cool. But when we're speaking to people who use drugs, we want to make sure that we're speaking to them as a person first. And when we are advocating for them, we are referring to them as a person first as well. So just a little bit of harm reduction history. When we're talking about harm reduction worldwide, it really started in the UK. So many SSPs come out of the need to address the HIV crisis, but as early as the 1960s in the UK, they were running syringe service programs. In the 1960s in the UK, there was a lot of actual heroin going around. We don't really see that on the street anymore. We see a lot of fentanyl or other opioid analogs. But in that, folks were still getting infections. There was still a lack of access to hypodermic needles for folks. So SSPs did come out of that need for people who use drugs. And then that need really blew up in the 1980s, in the late 70s when the HIV crisis hit the world. New York in our United States was actually the first to try and attempt to launch an SSP in 1985, right at the height of the AIDS crisis. But unfortunately, it was very stigmatized and it was struck down by the mayor. So then, in Connecticut in 1986, a former injection drug user named, and I always butcher his name, but John Ciant Parker, established the first ever SSP in the US in New Haven, Connecticut. So that was the first ever official SSP where folks were able to come in, get their supplies, get their knowledge, connect, and make sure that they have everything to stay safe with. In 1988, an individual named Dave Purchase began the first above ground needle exchange of its kind when he offered mobile and pop-up services. Mobile and pop-up services have become so popular in harm reduction because they are truly the epitome of meeting folks where they're at. We are getting in our vans, getting in our cars, and going to do outreach and going directly to those places where people who are using drugs are and getting them the services they need. Because sometimes, for folks who are using substances, it is hard to get to the exchange. It is hard to even just get on the bus that day. So by really bringing it to them, it definitely sees a huge change in folks. In 1988, when Dave Purchase started this, he started with a TV tray outside of his home, and folks would come up with one needle, he would give them another needle, and he had a mantra in this SSP work that I really love to share, and it is, you give me a dirty, I give you a clean, and it keeps your ass alive for one more day. So Dave Purchase was really a pioneer, and now we're lucky enough to have um, Dave Purchase and Nason, which are major harm reduction suppliers and their co-ops. So they're able to really help harm reduction organizations who are smaller or have lack of funding get the supplies they need out to the folks that need them the most. And of course, in 1988, the United States did pass a bill which prohibited any federal funds on SSPs. So that impacts SSPs today. A lot of SSPs across the United States rely on a lot of different patchwork funding to be able to get harm reduction supplies. I know in my SSPs, in my state, um, we're not able to buy things like syringes with federal funds. We're not able to pay for safe disposal of syringes with federal funds. So we have to go to outside donors to try and fundraise that money so that we can safely do harm reduction. And we can do it with the equity that it deserves for folks. We're talking about New Hampshire specifically. We are a little bit newer in harm reduction. It took us a little bit longer, but we really had some pioneers in the beginning who believed in the mission and pushed forward all of the legislation for the allowance of syringe service programs in New Hampshire. So early in 2017, NHHRC was founded, and we essentially were just a group of really passionate healthcare providers, doctors, educators, advocates who carried backpacks with syringes and distributed them to people who needed them the most. So once they got together, they officially formed NHHRC, the New Hampshire Harm Reduction Coalition, and we started to push for that legislation in June of 2017. And it was passed by Governor Sununu. So SSPs are completely legal in the state of New Hampshire because of that. In November of 2018, NHHRC became an incorporated as an independent nonprofit. So this was really big for us, being able to feeling like a bigger program, a more powerful program. In February 2019, NHHRC was granted 501c3 status. And in August of 2020, we were awarded our first New Hampshire Department of Health and Human Safety contract. In November of 2020, myself was hired by our past chair, Carrie Nolte, Dr. Carrie Nolte, and I was the first ever staff hired onto NHHRC, and I've been here ever since. I started as a care coordinator, so I've been working directly with folks since 2020, and before then, when I worked in a treatment setting. So I am the self-touting NHHRC historian. And then, of course, in early 2021, we were able to hire our executive director, Lauren McGinley, and the rest of our care coordinators who support folks in their substance use and support folks in their harm reduction journey throughout the state. Right now, New Hampshire Harm Reduction runs an exchange in Manchester, Concord, and the Tri-City area and the Seacoast. So we're super fortunate to be able to take care of folks the way we've been able to for this long, and to continue to do that work. So when we're speaking about harm reduction, there are so many things that incorporate it, and there are so many different strategies. We're going to get into detail about a couple of these today, but just to go over some basic harm reduction strategies is it's always going to be things like access to no-cost naloxone. Naloxone is the opioid antagonist drug that can reverse an opioid overdose because it blocks those receptors. A syringe service program, like we've been talking about, or the syringe exchanges, the actual programs that give out syringes and take them in and give out other harm reduction supplies, drug checking strips, we had mentioned, immunoassay strips like fentanyl test strips, xylazine test strips. We have nitazene test strips, benzodiazepine test strips. And the reason we have those is because the unregulated drug supply is unregulated. And with that, a mix of any adulterant can be in the supply that you are getting. So for folks who are maybe novice opioid users, or folks who are just using stimulants, or folks who are using recreationally and occasionally, it's really important to have those drug checking strips so that they're able to make decisions about their health and wellness. Healthcare coverage is always going to be an important part of harm reduction, because without healthcare coverage, folks are unable to access the things that they need, like wound care, MAT, MOUD, treatment if they want it, therapy, mental health. Those things are super important to folks who are using drugs. Housing first models are also important. Um, we have so many examples of folks who are not given that sobriety requirement when they go into housing. And because they're able to just have a home, somewhere to be, somewhere safe, they're able to regulate their use a whole lot easier. Everything becomes a little easier when you have a safe place to lay your head. Evidence-based treatment options. So there are some substance use disorder treatments that are not evidence-based, but we hope to advocate for treatment options for folks that are. Everything we do is evidence-based. Everything you see from me today is evidence-based, of more than 20 years of um, peer-reviewed analysis on harm reduction and how it works. So we hope to um, push the state of treatment options for folks in that evidence-based um, format. Criminal justice reform is always going to be something that is a tough one, especially when we're talking about illicit substances. But in harm reduction, we truly believe that the morality of a substance is not connected to the substance itself. It is simply just a substance that you get a psychoactive effect from. It has no morality attached to it. So it's neither good nor bad. It is just a substance. Drug policy reform. So these are things like when we think about um, folks who have mandatory minimum charges for something like cannabis, very low nonviolent crimes when folks have cannabis on them, and then they are still in institutions or jails because of that charge. And unfortunately, the state that they live in has completely legalized cannabis. So that's like the kind of reform we're talking about, is if, that the um, drug classification and the legality behind that drug changes, then the policy should reflect the people first and their needs. Supervised consumption sites are, of course, we already kind of mentioned, spots where folks who are using illicit substances are able to go and stay safe because they have medical staff around them that can intervene in case of any kind of overdose or other medical emergency. Um, and then, of course, a safe supply. So when we're talking about an unregulated supply, I think the biggest pie in the sky wish for a lot of harm reductionists is, how do you stop overdoses? You give folks a safe supply. And safe supply can be things like medication-assisted treatment. It can be things like methadone, Suboxone. These are safe supplies because we know what is in that. It is regulated. Um, and in some places like Canada and I believe Holland, they have stuff, things called the Heroin Project, where folks who are using opioids are able to get a regulated supply of that drug and use it. Um, and they're able to use it as they wanted to in the first place, as medicine. And they feel safer in doing so because they have access to something that has been tested and true. Um, but all of these things, overall, most important piece is they reduce death, they reduce mortality for people who use drugs. When we allow SSPs in our communities and drug checking strips and housing first models and healthcare for people who use drugs, it reduces death. Um, And I think sometimes we get stuck up in the stigma of the opposite, that if you're giving people access to these things, then they're more likely to use more and pass away. But um, the evidence will definitely show us that it is exactly the opposite. Some of you may be wondering why harm reduction. Um, there are so many reasons why, especially when it comes to your personal journey in recovery or your personal journey in um, just life in general. But when we're talking about harm reduction, it is a framework for working with people who use drugs. You know, we frame our entire conversation around a strive for positive change. We make it person driven versus coercive. We make it supportive versus punitive. And the reason why we do this is because it's proven that when folks are given that um, openness and freedom to make their own decisions, to make their own choices in a system that has historically taken that away from them, they are more likely to engage with programs. They're more likely to engage with you as a provider. And that's incredibly important. When you have folks engaged with you consistently, they are more likely to heal. They're more likely to continue to do things that strive for that positive change, because they've been given their humanity back. It's also a framework for understanding drugs and drug use. Drugs and drug use is incredibly complicated, but when we talk about it in harm reduction, we're viewing it through a lens of science and evidence, not morality. And we acknowledge that some drugs and drug use are safer than others. In the United States, we have a completely safe supply of one of the most toxic drugs out there, alcohol. We tried to get rid of it once, and prohibition just does not work for humans. But we can acknowledge that that regulated supply is much safer than any unregulated supply that folks are getting on the street for illicit opioids, illicit stimulants, and anything else. We also acknowledge and address the context of drug use. Um, so you have your drug, your set, and your setting. So when we're talking about that, your drug is the physical substance you are doing. So what kind of effects do you expect from it? What did you buy? What do you hope to get out of it? Why are you using? Are you looking for pain relief? Are you looking for an experience? What kind of things go on with that actual substance? When we're talking about the set, we're talking about your mindset. Where is your mind? I'm sure so many of us have heard, especially when we're speaking about hallucinogenics, that before use, it's so important to be in a positive mindset. And that is important for every single substance. Not even just a positive mindset, but understanding where you're at and what this substance can do for you. And then, of course, the setting, the environment that you're in. If you are in an environment where you don't feel safe, and you're afraid, that can cause mistakes. That can cause things like overdose or injury. When you are in a safe space with people who love you, with people who want to take care of you and make sure that you are safe, you're much more likely to make sure your friends know what you're using, have naloxone on you, and make sure somebody knows how to use it. And you're much likely to test your substance, use less, and follow those harm reduction steps to be able to, make those positive health and wellness decisions. Um, I think it's really important when we speak to folks who use drugs, we're using language that is not stigmatizing. So there was a study done by the Recovery Institute, and they asked participants how they felt about two individuals. Um, who were actively using substances. One individual was referred to as a substance abuser, and the other was referred to as a person having a substance use disorder. And what they found out of that study is that when someone was referred to as a substance abuser, individuals were more likely to, excuse me, individuals were less likely to benefit from treatment, they were more likely to benefit from punishment, and they were more likely to be blamed for their substance use related difficulties. Now, in this study, there was no difference between the two individuals other than the way we referred to them. Um, there's a really wonderful resource in the Recovery Institute called the Addictionary, and it can help provide ideas and terms that are less stigmatizing when we're speaking to folks who use drugs and we're speaking about them. So it's not just when we are talking directly to the person who using drugs, but when we are advocating for them, when we are speaking about them in our clinicals, when we are speaking about them in our supervisions, when we're speaking about them with our friends and family, it is so important to use that language that does not stigmatize them. Um, so with less stigma surrounding like alcohol and other use disorders, individuals with those conditions are more likely to seek treatment. So when we change our language for other kinds of illicit substances, folks are more likely to enter into recovery. And recovery can be anything that an individual wants it to be. So harm reduction, I'm sure we've all heard, is meeting people where they're at. And that's a spectrum of strategies of meeting people in a variety of goals. So it can be safer use, managed use, or complete abstinence when you're using no substances. Um, we can see here that we have the stages of change. And when we are working with somebody in harm reduction, I think it's really important to remember that they can be anywhere on this spiral, anywhere. I think a lot of the times before folks enter into treatment, we expect them to be in at least contemplation phase. They're aware of a problem, but they have no commitment to action. In harm reduction, when we're speaking about specifically recovery and treatment, um, someone can be anywhere. We just want them to be able to make the decisions they want to make and make informed decisions, so that they're able to really have control over their health and wellness. Um, and I think the other important thing is someone who is participating in harm reduction when it is specific to their recovery can go through this cycle as many times as they need to be able to reach where they want to be. Um, I think every time they do have a reoccurrence or a relapse, I say it's a reoccurrence when we're speaking about substance use disorder, because like any other chronic disease, sometimes it reoccurs and pops back up. Um, but that doesn't mean that we have completely lost our health and wellness, that we have completely lost our connection to recovery. Just means it has popped back up and we address it how we need to. But every single time someone comes around this circle, I think that they're gaining another piece of knowledge about themselves and their recovery, and they're really able to understand it from a point of their own decision and their own power. All right. So another thing is that when we are speaking about people who use drugs, not every single person who uses drugs has a substance use disorder. There are people who use recreationally, there are people who use to manage pain, there are people who use here and there. There is such a wide spectrum of use and how that connects to people. But when we're specifically talking about people who use drugs, who have substance use disorder, they do have to meet a definition of recovery. So I have one of my favorite guys right here, Dr. Carl Hart. He's a professor at Columbia, famous for his studies on folks who use crack. And he is just a phenomenal harm reductionist. I 100% say go look him up on YouTube and just watch a couple of his TED Talks. It always brings me to tears. He just has such a beautiful view of people who use drugs, and he has such a beautiful story of lived experience. He was somebody who grew up in Miami, um, sold illicit substances, used illicit substances, but somehow he did the opposite of what we've been told substance users can do. He became a professor, he became a doctor. And now he's world renowned at what he does. And another important thing to note is he is someone who is very open about his recreational substance use. He believes that you can recreationally use things, even if they are illicit, and not form a substance use disorder. He has a really famous quote that I believe is in one of his TED Talks that said that where he says, you know, why would somebody asked him in this conversation about how do you recreationally use heroin sometimes? And he kind of looked at them and said, well, in the same way where I wouldn't show up drunk to this interview, I use heroin recreationally for myself, for my enjoyment, and I do it safely. So he's really able to beat down a lot of that stigma about drug users. So he has a like very clear-cut definition in his book Drug Use for Grown-ups, another beautiful recommendation. It's an awesome book. Where the DSM-5, outlines what addiction is, what substance use disorder is. So it is an individual's drug use must interfere with important life functions such as parenting, work, and intimate relationships. Use must take up a great deal of time and mental energy and must persist in the face of repeated attempts to stop or cut back. Other symptoms that the person may experience include needing more of the drug to get the same effect or tolerance and suffering withdrawal symptoms if use suddenly ceases. So these are the things that make a substance use disorder. There are folks out there that are doctors, lawyers, parents, who recreationally use illicit substances of all kinds. And they're still able to function. They're still able to have the exact life we would imagine them to, even with those substances. So we really have to me, this is really pulling apart the misinformation about substance use disorder. Because you use drugs doesn't mean you automatically have a substance use disorder. It just means that you use substances. So, so as we have here, we have the continuum of excess, moderation, and abstinence. I'd like us to pause and imagine that we are speaking about diabetes here instead of substance use disorder. If we're talking about the disease model, then we can talk about it in the exact same way we counsel somebody on how to take care of their diabetes. And, while the disease model has some flaws and not everyone applies to it, like I had mentioned before, it does give us a good framework for how to speak to people about why SUD is completely different than recreational use, and it tries to reduce some stigma for folks. Some people just have unhealthy relationships with specific substances, and your boundary and your relationship with any substance can change over time, or sometimes it can't, but it is always going to evolve. Someone can stop using dope to smoke meth or crack, which is harm reduction, and some might switch from injecting to smoking. That's also harm reduction. When we're looking at this chart here, when we're talking about a chronic illness, any step towards decreased risk is a step in the right direction. And we're talking about risk, not decreased use. So if somebody is on this staircase and they're in excessive use, they have an incredibly increased risk for health complications, death, suffering. And that means that their chronic illness is less controlled. When they take one step towards moderation, they are moving to decrease that risk. And their chronic illness is moving towards being more well controlled. When we're in that moderation, we're maybe if we have diabetes, our sugar's better, We're really listening to what the doc's saying. We're taking it seriously, but we're still eating a couple extra cups of pudding. Um, but we're still moving towards that decreased risk. And then when we move into abstinence, we have completely decreased our risk, and our chronic illness is more well controlled. The same exact thing happens with substance use disorder, not just substance use. So, um, when we are speaking about folks who use drugs, um, there are so many various kinds of sensationalized media and misinformation. So we're going to go through a couple myths that I think are a little silly, but we're going to just kind of weed out the important pieces of it. So especially with sensationalized media, um, there are so many times when substance use disorder or a specific substance is demonized. So here we're talking about specifically the difference between crack and cocaine. Only difference between the two is salt. And what we mean by that is the actual, when we say salt, we mean like the chemical form, like hydrochloride, is being removed. It is evaporating. And that's what concentrates into a crack rock. So it is essentially the exact same substance. You get the same effects. But as we've known historically, there's a huge difference between the prosecution of crack and the prosecution of cocaine, and who uses cocaine and who uses crack and the kinds of people they are and where they fit into racial disparities and gender disparities, um, socioeconomic disparities. So we can understand that there is really no difference between the two substances. They're basically chemically identical, um, other than crack having that hydrochloride salt removed. But that hydrochloric salt has no psychoactive effects, so it's really not changing the actual chemical compound of the drug itself. It's not changing that psychoactive effect of the drug. Um, but back in the 1980s and 90s, um, there was, of course, a lot of stigma and misinformation about crack babies, and this absolutely affected people of color. And in that, there was some research done that's demonstrating that the long-term effects of crack on the quote-unquote crack babies in the 1980s and 1990s is actually less severe than alcohol. So individuals with like fetal alcohol syndrome are having more severe long-term effects than folks who have had like crack use through their pregnancies. And although there were some negative effects, the impact now appears to be similar to mothers who smoked cigarettes while pregnant. Um, Current research is showing lower birth rates that caught up and no significant differences in IQ or language or development. There have been some signs of increased behavioral problems, but there are studies that show that that probably has more to do with like your socioeconomic standing and your ability to feel safe in your environment than the actual use of the crack. Um, so here, this substance was used to demonize and control a specific population of individuals. And it has done so continuously. It does so to this day. Folks speak about crackheads or people who use crack entirely different than people who are using cocaine. When you think of a generic person using cocaine in your head, you're thinking of a businessman, a party guy, Wolf of Wall Street. When you're thinking of crack, you're thinking of somebody who is, maybe they're having some twitching, maybe they're having some physical movements, maybe they're a little erratic in behavior. And maybe they have a completely different dress of like there is poverty going on here, there's lack of um, education, all these things. So we have so many negative connotations to crack versus cocaine when there's only one chemical difference between them. Another stigmatizing myth about folks who use drugs, and I do think that this might be the silliest of all, because it's just not based in any kind of science. It's really based in misinformation about opioids and synthetic opioids like fentanyl. So Narcan parties are absolutely a myth. People who use drugs are not having Narcan parties. Narcan or naloxone is the opioid antagonist that reverses an opioid overdose. And there had been some media sensationalism around, folks who are using illicit fentanyl. Um, they would use and use and use and use and use at these parties until they overdose, and then everybody just gets Narcaned, and they keep using and they keep getting Narcaned. Um, no one would voluntarily indulge in a purposeful overdose if they are looking for just continuation of use or trying to escape the pains of withdrawal. When you are given an opioid antagonist, you are put into precipitated withdrawal. Precipitated withdrawal for folks is incredibly painful and uncomfortable. I remember when I worked in a treatment setting, our biggest fear was if somebody took their Suboxone too quickly after coming into our rehab, that they would go into precep. And folks had gone into precep, and their reports always were it's worse than actual withdrawal. Because those receptors are being blocked. Um, so no one is looking to do that on purpose. It's just not something that happens in drug use communities. But I think it comes out of a lot of misinformation around fentanyl. I think that unfortunately there has been a lot of purposeful misinformation about fentanyl so that we can put stricter drug policy around it. But unfortunately, what it does is it really negative affects people who are using fentanyl, um, and it negatively affects the rest of us when we are seeing somebody on the street having an opioid overdose. And we feel like we can't intervene because we believe that there could be some kind of incidental fentanyl exposure. I will say this probably 3 more times during the presentation, but fentanyl contact does not cause overdose. We have skin on our hands, in our face, on the rest of our body. Skin is our biggest organ, and it is on us because it is meant to be a protectant. It's supposed to keep things out of our body. But there has never been a documented toxicology result to confirm incidental fentanyl exposure. It's a myth. It's often perpetuated by law enforcement and the media, and experts in toxicology widely believe it's nearly impossible. We've all seen videos of law enforcement officers having a reaction to something that they think is aerosolized fentanyl, where it can just get in the air and then you instantly overdose. Um, but unfortunately, it's just not scientifically accurate to the actual composition of the drug. As long as we are not getting any substance in our eyes, our nose, our mouth, or any other mucous membranes on our body, um, then we are not going to get a psychoactive effect. There had actually been a study done by a toxicologist that said, and I believe it was um, 3 hours that you would have to, if you sat in a wind tunnel, filled it with fentanyl, you didn't wear goggles, you didn't wear a mask, and fentanyl blew around you for 3 hours, you might get enough in your eyes, nose, and mouth, as I believe it was 3 nanograms. And if it was pure fentanyl, then that could possibly be enough for somebody, but everybody's body chemistry is so differently. Everybody's body chemistry is so incredibly different that overdose happens differently for everybody. And especially when we are talking about an unregulated drug supply, we have no idea the concentrations of that for example, a bag of something. We have no idea how much is baby powder, how much is fentanyl, how much is gabapentin, how much is aspirin. It could be an entire mix of those things. The reason why fentanyl is cut with so many other adulterants is because it has a powerful high, but it also has an incredibly short half-life. There are folks who are using bags of fentanyl or what they believe to be fentanyl that have to re-up their use every 30 minutes, which is crazy. And that usually has to do with how cut down that bag is. So it's not pure fentanyl. Nothing on the street is going to be 100% bag of fentanyl. It can be a myriad of other things mixed into it. Some more stigmatizing myths. When we're speaking about folks who use methamphetamine, stimulants, they get a different kind of stigma, right? We have really mean names for folks who use stimulants, folks who use meth, and we think that they can't hold jobs. We think that they can't be productive members of society, which, whatever that means, that they can't be parents. But there are people who recreationally use meth, and they're fine. Um, but specifically, when we're speaking about like the physical appearance of somebody who uses drugs, things like meth mouth are not real. Um, you know, it is a stigmatizing and inaccurate term, and it doesn't have any science behind it. So people who use drugs are often facing housing insecurity and financial insecurity. So sometimes that can result in barriers to nutrition, medical care, and dental care. Um, it is incredibly hard as a person who uses substances chaotically to access dental care for any issue. I think it's hard as anyone in the United States to access dental care. It's incredibly cost prohibited. But the physical changes to someone's mouth and teeth um, that occur in these like dramatic posters we see. I remember, I believe it was Oklahoma, had a campaign that said like meth only once, and it had an individual's mug shot where she was first arrested, and she looked perfectly fine and healthy, and then her last arrest photo where you can see that living on the street has done some damage to her. And that had everything to do with her lack of access to dental hygiene, to acceptable nutrition, um, and of course, poor sleeping habits. That's the other thing about stimulants is they really affect your sleeping habits, especially when they're unregulated because we have no idea how much is in our supply, so we don't know what kind of effect we're going to get. A lot of people use things like methamphetamine to stay safe when they're living on the street. Folks will use methamphetamine so that they can stay awake during the night, so that they can keep their physical body and their things safe. Um, so that no one is hurting them or stealing from them. And then sometimes they'll use opioids in the morning so that they can get some sleep. But a lot of folks are unable to sleep at all. There's plenty of, there was a book written called Rough Sleepers, and it's about the unhoused population in Boston and the doctor that cared for them. It's a wonderful book. He's a hero. Totally recommend it. But like, there's a reason why we call them rough sleepers. Um, and sleep has so much to do with all the other aspects of our health and wellness. If we're not getting enough sleep, then of course we can act erratic. We can be irritable. We can be maybe even a little ridiculous sometimes. But I'm a mom and I've been without sleep, and I very much understand what the feeling is after having zero sleep and how um, on that precipice of just crazy you can feel. Um, but a lot of this mouth misinformation comes from that media sensationalism. And it's unfortunate because it is really stigmatizing folks who use drugs, especially stimulants. Um, Another myth that I see off and on, but not as often as we used to in the past. But there's been no reliable data that demonstrates those who are dealing illicit substances are targeting middle schoolers or children. Nobody wants children ingesting fentanyl or illicit substances. And this is a myth motivated by instilling fear in the public, often motivated by the ability to improve funding to um, various law enforcement efforts. So anecdotal stories fuel this, not data. It's always important to remember that stories from your brother's best friend's cop dad is not evidence. It's not evidence. It's a story. And sometimes we are told stories that are so scary. And when scary things happen to us in our brain, we want to blame someone and we really want to define someone as the bad or deem them as evil. But people who sell drugs represent so much more than how they make money. Um, they make up members of the community who value and love people who use drugs. I've had folks come to my exchanges who sell illicit substances, and they come and gather supplies. They gather naloxone and syringes and other tools to stay safe because they want their folks to be taken care of. I had one individual who would donate to the exchange every time he came by, big bills. So it was definitely a large donation every time. And he would say, I don't let anybody leave without naloxone. Um, you know, if we're removing the love and caring from it, people who are selling drugs don't want to kill off their business. They do make money off of it. They do create livings off of it, and they don't want to kill off everyone. That's definitely some misinformation. This is just a really, I love this chart because it really shows the process of where we've gone throughout history with various substances. And the harder the enforcement, the harder the drug. I th that is a huge reason to why we have fentanyl in the US today. Um, you know, we can see here that like we start with beer and wine, then prohibition kicks in. Folks move to homemade spirits, bathtub gin. Prohibition gets harder and harder and harder. So folks start running moonshine. Um, and like we know, moonshine is incredibly potent. Um, and the process in which folks got out moonshine is very similar to the process in which really any illicit substance today gets out to people. You have runners, you have people hiding things, the like less weight and volume. You want to make things more potent so that they're easier to store and hide. When we're talking about cannabis, we've seen cannabis is a little different because of the legalization across various states. But folks, they have regular cannabis plants, then we're moving to higher concentrations of THC because we want to be able to have more on us in a smaller amount. We want to be able to transport it. And then sometimes we can move into those synthetic cannabinoids. I think that a lot of dispensaries and whatnot have like moved away from all of that, and we're kind of just at high THC cannabis. It has things on it like bud enhancers is what they call it, so it can give a higher THC than um, I always call it like then your dad's weed. But so what we get at dispensaries really kind of kicks the old timers' butts, right? And then things like cocoa leaves or tea. These are things that like indigenous groups have used for ever. Just chewing on leaves. Little grandmas will still do it. But then it moves to powder cocaine. And then, of course, like that concentration of the removal of salt, crack, opium. We've all heard about opium dens or smoking dens. From there, it changes to heroin. And we in the early 1800s, I believe. We used it as a medicine. It was a very effective medicine for pain. And then from there, we need something higher, more potent, to really increase the potency of that substance. We have things like fentanyl and carfentanil. Um, and while these are a higher potency, um, I think it's important to remember that fentanyl and carfentanil are opioids. They're different analogs of each other. Um, but when we're talking about, like the grain of rice of fentanyl or the potency of it, it's really hard to determine the actual weight versus the potency of a drug in an unregulated drug supply. Um, and then, of course, we have stimulants, so ephedra, amphetamine, and then ice or methamphetamine. Um, these are things that we prescribe to people. Um, Amphetamines were called mommy's little helper for a very long time because they gave you that stimulating effect and they allowed you to do so many more things without sleep. So, this whole chart was created in 1986 by Richard Cowan, and it really just like outlines the change over time and how prohibition just doesn't work for humans, unfortunately. I think we all know that when you tell us to do something, we really push back against it. So, it's not so much that potency needs to change, but that chemical experience change what is going on. So, like new chemicals need to be developed to hide from law enforcement as we move closer to carceral systems and we move farther away from a safer supply. And the more we push on carceral systems, the more damage we're going to do to folks who use drugs. So, these are a couple of real statements from people who were looking to access substance use treatment in the state of New Hampshire in the year 2016. This was done by one of our founders, Dean Lemire. We lost him a couple of years ago, so I always like to include these because I love to have him a part of our presentations always. But he went out and he interviewed people who use drugs in the state of New Hampshire who are lacking usually housing, they're lacking social connection, and he got the words directly from them. So these are the words of people who use drugs. And I want to read this verbatim because I think it's really important to remember that this is a reality for people who are trying to access treatment. So when the cops get called about someone using in public like that, it's not like they come in and try and help you. They surround you, they throw you to the ground, they rip things out of your pockets. If you're sick, what they mean by sick is if you're having withdrawal pains, if you haven't been able to use your substance, if you didn't get to feel better before they showed up, it's 100 times worse by the time you're done with them. My biggest thing when I was trying to get clean was that there was no help. I was trying to get into a rehab or into a program. There was no help. I had to go to the hospital and tell them I was going to hurt myself. This is an unfortunate reality for folks who use drugs, not only in the state of New Hampshire, but worldwide. I can share from personal experience. I've brought loved ones to the hospital and had to say they won't hold you unless you're going to hurt yourself. Um, and it is so incredibly dehumanizing and sad that this is what folks who are begging for help are have to resort to. Um, there isn't enough access to treatment for people who use drugs, and there isn't enough equitable access to treatment. So let's see the next one. What we're most in need of is free medical detox. The number one reason anyone remains an addict is because they're scared to go through withdrawals. I would be clean right now if there wasn't withdrawal from heroin. I think a lot of addicts would. And I would be clean right now if there was readily available medical detox that you could just go in, say, I'm an addict, I need help, and they admit you. I know programs like that are far and few between, especially New Hampshire. Especially New Hampshire is the worst place for treatment in the country, pretty much. I've tried so many times to get help, and it's almost like they try and run you around in a circle and pass you off to each other and just keep you going in circles and you get nowhere. Um, I think this is like really hard to hear that this is someone's experience when they are trying to access treatment. Because what is the thing that we hear the most about people who use drugs is they don't want treatment, they don't care. But that's not true. It's that folks have been so stigmatized in the past by carceral systems, medical institutions, uh, treatment centers that they feel like they have no other choice. They feel completely lost at sea, like no one can help them. Um, to me, I don't think that New Hampshire is the absolute worst place in the country to access treatment, but we have so many steps to make it better for folks. And of course, these were done in 2016, so there has been years between it. But the sentiment from people who use drugs that have SUD that are looking for treatment has not changed. Um, I think that folks who use drugs need more access to detox, especially when you are going into some treatment center that maybe is not fully medicalized, but with our incredibly unregulated drugs supply, you might think, I've only ever been taking opioids, that's all I ever have in my system. But you find out after a urinary analysis that you have benzodiazepine, nitazene, xylazine in your system. When you have benzodiazepines in your system, you need a safe medical detox, or there is a huge risk for death, seizures, a litany of other issues. Um, and that can really stop someone's forward momentum. You know, it is an incredibly hard decision to decide you're going into treatment. And when you are ready, it needs to happen right then and there. That you're able to get into it, that you're able to be safe, and that you're able to stay in that mindset. So, when folks are unable to get into detox, it absolutely impacts their treatment and recovery for the long term. Just a reminder, you cannot do the same thing over and over again and expect different results. This is the definition of insanity, right? I feel like a lot of substance users, myself included, when going through the recovery process, when they spin you around in those circles, it absolutely feels like you're insane. It absolutely feels like there's only something wrong with you. Um, but that is not the case. And that's why we really believe that we're doing it differently. And we'll continue to do it differently for folks who use drugs in the state of New Hampshire. And just a shameless plug, this is our beautiful overdose prevention van. Her name's Carrie. We love her. You might see her around Concord or Manchester doing our thing. Feel free to stop by and say hi. So, drugs, the basics. Um, let's see. So, what's a drug? Basic question. It is a psychoactive substance that produces a state of arousal, contentment, euphoria, or some kind of sleep-inducing property. Tons of different things can be drugs. Um, your insulin is a drug, and crack is a drug. They have different psychoactive effects. They have different states that they put you in, and they have different properties. They have different reasons why you use those for your body. Some drugs can result in dependence when used continuously or excessively. That's when withdrawal can happen when you stop. But regardless of illegal or illegal drugs, this has very little to do with the potential for dependency or harm. The only thing it does have to do with is the impact on the individual, that may be crime involved having SUD. So the individual is the one impacted by the legal status of the substance, but it does not determine how harmful that substance is going to be or how dependent they will be on that substance. So, how do we use drugs? There are so many different routes of administration. We eat it, we take a pill, we smoke it, smoke a cigarette, we snort it, snort cocaine, we inject it, inject any, so many different drugs, not any, but various kinds of drugs. I think when we're thinking of injecting, we're thinking of opioids, or we put it in our rectum or boofing. So each different route of administration is, important for several different reasons. Like if somebody came to my exchange and they said, my veins are awful right now, I can't inject, but I cannot go through withdrawal pains, I won't live through it. Some people have died from precipitated withdrawal, from withdrawal in general. People have absolutely died. Um, so I might say, okay, how do you feel about snorting? And I will give them a safer sniffing kit. I'll talk about the entire process and the tools that they need to stay safe and how safely they can do it. They say, I don't like that either. So maybe we'll try smoking. And I'll give them a glass pipe that you can see here. Those are pipes that would be used for methamphetamine smoking. And they said, I don't really want to smoke it either. So sometimes a really good alternative is boofing or putting it in your rectum. It's easier for folks who are able to be a little bit more secretive than, setting up your works with a needle in the bathroom. You're able to like pull up your substance, mix it with water, put it where it needs to go, and then you're on your way. You're still getting that effects to where you're not sick, but you're trying to change that route of administration to give the other parts of your body a break. In any kind of substance use, no matter the kind, it's important to switch up your routes of administration. So, drugs. I absolutely love this chart. It's called The Drug Wheel. It's by Mark Adley and Guy Jones and Michael Lennon. The website is below. It's called thedrugwheel.com, and you can see all the various kinds they have. But I love this one because it really breaks up the differences between the psychoactive effects of all of our drugs. So stimulants, uppers, increased energy, increased heart rate, euphoria, dilated pupils, paranoia, anxiety, sexual arousal, impotence or come downs. So those are things like methamphetamines, Adderall, things like cocaine or crack, those are all stimulants. Empathogens are the loved up or connectedness. They're warm, understanding, but you can sweat, you can have arousal, you can have mood swings or depression. So those are things like MDMA, psychedelics, so LSD, mushrooms, you have trips or that spiritual connection, heightened senses, visual or auditory hallucinations. Anxiety, panic, mental health issues. Sometimes, for some folks, psychedelics don't mix well with their brain chemistry. Dissociatives um, are things like, I believe, excuse me, things like GHB. So it's that out of body euphoria, floaty, disconnected, relaxed, numb. Sometimes you can be scared or unable to move or in a hole. Dissociatives are things like ketamine, be in a K-hole. Um, Cannabinoids, you're stoned, you're calm, you got the munchies, chilled out, floaty, giggly, sensually. Sometimes you can be paranoid or have dry mouth or have anxiety. You can be lazy, and for some folks, cannabinoids can increase mental health issues. Depressants, alcohol, biggest depressant. So buzzing, euphoria, confidence, relaxed, risk-taking, withdrawal, unconsciousness, coma, vomiting, or death. And then, of course, opioids speak for themselves. It gives you that invincible kind of confidence, pain-free, safe, euphoric, constricted pupils, addiction, hallucinations, withdrawal, overdose. Um, it's good to note that like cannabinoids actually used to be in the psychedelics, the dissociatives, the opioids, like they used to be in several different categories, but there's such a complex structure chemically that we had to put them in their own group because they're their own thing and they don't act like any other substance. But what I really love about this is it gives the more positive psychoactive effects and then some of the negative things that can happen because any substance can have that positive effect and that negative effect. It's all based on your brain chemistry, how you're using that drug set and setting. Those are all important. So we're going to get into detail about a couple of the drug categories. Some of the most popular throughout at least New Hampshire. So opioids, of course, are the most popular substance in the state of New Hampshire when we're speaking about people who are using drugs, um, tied very, very closely with methamphetamine. But what do opioids do? Well, they attach to opioid receptors in your brain and they block pain. They can give that antidepressant effect, they can make you feel drowsy, they can make you feel calm, and they can cause overdose. But I think it's important to remember that opioids target the brain's reward system and they flood that circuit with dopamine. Dopamine is a neurotransmitter that is present in regions of the brain that regulate movement, emotion, cognition, motivation, and feelings of pleasure. Dopamine is that like happy chemical. We always are looking for it. When you overstimulate this system, which rewards our natural behaviors, the brain really likes things that make us feel good. It produces this euphoric effect, and that is really sought out by people who use drugs, and it teaches them to repeat that behavior. Our brains are wired to ensure that we'll repeat life-sustaining activities by associating those activities with pleasure or reward. And I think that when folks are using opioids, they're in pain. They're in mental pain, emotional pain, physical pain is usually where it starts. And so when our brain sees, oh, I don't have to be in pain, I need to continue that. I need to keep pumping out dopamine. I need to keep this system overstimulated. Whenever that reward circuit is activated, the brain notes that something important is happening that needs to be remembered and teaches us to do it again and again without thinking about it. Um, but because some drugs stimulate the same circuit, we learn to use drugs the same exact way. When we're speaking about opioids specifically, there's a difference between tolerance, dependence, addiction, and disorder. Tolerance is when you need more of the drug to get the same feeling as the first time. Dependence is when you need that drug or you will have withdrawal symptoms. You know, addiction to it is not equal to a disorder. Um, and dependence is not equal to a disorder. It is a physical dependency, not a disorder. So we're speaking about specifically opioids. Here's a list of some of the popular ones and how long they last in your system. So something like methadone, that lasts 24 hours, one day. That's why people go to the methadone clinic every day, so that they can get their medicine because it is a medicine for them. Heroin, when we had it, I'd say that heroin went away probably in 2017 is when we saw the real surge of fentanyl into, especially New Hampshire. Heroin, when it was a little bit more in its pure form, was 6 to 8 hours. But again, in that unrelated drug supply, it can change. Oxycontin, 3 to 6 hours. Codeine, 3 to 6 hours. Demerol, 2 to 4 hours. Morphine, 3 to 6 hours. So like these are long times to have that effect. Like I said earlier, fentanyl in its current state in the unregulated drug supply can have a half-life of 30 minutes sometimes. People have to re-up their use every 30 minutes, depending on what their tolerance is, depending on how much they're using, depending what's in their bag that day. If they get something that's 99% baby powder, then they're going to need a whole lot more after that. Stimulants. So stimulants are all kinds of different things. The most popular stimulant in the entire world is caffeine, coffee. I have caffeine right next to me right now. I love it. Um, but it has the same psychoactive effects as any other stimulant in lower concentrations. Things like cocaine, meth, speed, crack, ecstasy, those are all stimulants as well. When we're talking about specifically prescriptions like Ritalin or Adderall, it affects our alertness, our attention, our energy levels. It can elevate our blood pressure, it can make us sweaty. It can increase our heart rate and respirations. It can constrict blood vessels and increase blood glucose. Um, when we're talking about the actual chemical composition of meth and Adderall, there is not a huge difference between the two. Um, I love to remind folks of this because it's the same thing like we talked about with crack and cocaine. One um, is, Adderall, that's a safe supply, and one is meth, that is not a safe supply. But as you can see here in this little graph, is they are about one CH2 molecule off. Other than that, they don't have a lot of differences. There's not a lot of psychoactive differerences between the two. So we know what happens when we take too many opioids, but what happens when we take too many stimulants? Well, we call that overamping. It's essentially a stimulant overdose. It can happen in a lot of different ways. Um, it's a lot of the time it's very behavioral. So behavioral symptoms like extreme anxiety, panic, paranoia, hallucinations. You can be very agitated, hypervigilant, enhanced sensory awareness and suspiciousness. That paranoia really eats and eats and eats. And usually what happens with overamping is it is not just because you took too many stimulants, but it is the mixture of a lack of nutrition, a lack of sleep, and a lot of stimulants. Um, this doesn't mean that everybody who uses stimulants is going to become erratic and agitated. It means that when folks are really at their wits' end with stimulants, they can have these behavioral symptoms. The physical symptoms are, nausea and vomiting. They can pass out, but still be breathing. That's the important part. Have that chest tightness, high temperature, they're sweating, but they're cold, like they have the flu, false heart rate, racing pulse, hypertension, irregular breathing, or shortness of breath, convulsions or tremors, stroke, feeling paralyzed when awake, severe headache. Um, so it's not comfortable to do too many stimulants. It's really not comfortable to have too many of any substance in your body. We always have the harm reduction tip to stay safe. That's you go low, you go slow. You can always do more substance, but you can't do less. Another drug that we've been finding in the drug supply in New Hampshire is xylazine, aka trank. You can hear folks refer to it as trank or trank dope. It's being found alongside a lot of the illicit fentanyl supply because fentanyl has such that short half-life. Xylazine, being a non-opioid veterinary tranquilizer, kind of beefs up that experience for some people. It extends the half-life of fentanyl, or it gives it legs, as some people might say. But it is entirely different high, and it's very, very dangerous when mixed with fentanyl because xylazine does not have any kind of available, like antagonist, like naloxone. There's no equivalent to xylazine. The presentation for people on xylazine can include like an incredibly deep nod, but still breathing. Um, Folks who are using xylazine with or without their knowledge notice significant wounds that look like horrific burns that take forever to heal. Um, you know, Even when they're smoking, if they're not injecting, folks have still seen it when smoking, snorting, anything. Um, folks can get necrotizing fasciitis after a while if they're not, if their xylazine wounds are not cared for correctly. Currently, in the state of New Hampshire, we don't have any drug checking services. So the best that we can do for our participants is show them and teach them how to use xylazine test strips, like you can see here. So that at least tells them yes or no if xylazine was involved in their drugs. Um, but it doesn't tell them how much, and it doesn't tell them if they'll have a more severe reaction to it or if they'll have wounds. So they're able to get that knowledge and they have to proceed with caution as best they can. Um, but xylazine was involved in 19% of all drugs overdose deaths in Maryland in 2021. And I think the latest statistic in Pittsburgh has been that of because they have drug checking services there, of all the drugs that they check in their service, that about like 90% of those substances have xylazine in them. So it definitely has different pockets that it'll pop up in culturally, but it is an incredibly hard drug to really regulate for safety of use. Some folks look for it. Some folks really enjoy that kind of trank dope feeling. Um, but I would say that it is not super popular among folks in New Hampshire. But um, I would say almost all polysubstance use is unintentional when you have an unregulated drug supply. You don't know what you're putting in your body, so you are unintentionally putting xylazine, baby powder, gabapentin in your body when you're using an unregulated drug supply. There, of course, is polysubstance use that is intentional, but that means that you have an idea of what you're able to put in your body and you want to mix drugs. So some other types of common substances, and pathogens. So we're talking like MDMA, some lesser known ones like PMA, but they all kind of do the same thing. Depressants, alcohol, benzodiazepines, GHB or kava. Um, Cannabinoids is anything weed, synthetic or not. um, Dissociatives, ketamine, DXM, nitrous oxide. Um, some people call it hippie crack. um, Psychedelics, LSD, psilocybin or mushrooms, salvia, DMT, mescaline, ayahuasca. Um, these are some other things. I wouldn't say that any one of these is specifically popular in New Hampshire. Cannabinoids are popular everywhere. Um, Benzodiazepines are being found in the supply throughout New Hampshire again, so that's always a worry, especially in the polysubstance world, and especially trying to get into treatment access. For New Hampshire drug trends, we kind of already touched on this. So xylazine is being found in a lot of the opioids, but it can also be found in any other unregulated supply for stimulants. Fentanyl is absolutely being found in things sold as stimulants. So if somebody is looking for meth, but they're having a sleepy reaction to it, then usually we'll tell folks like, hey, take this fentanyl test strip, tell me if there's fent in your meth. And a lot of the times they come back and say, wow, I was so surprised that there was fentanyl in my stimulant. But so folks that don't have an opioid tolerance, that are just using stimulants, it's so important for them to use fentanyl test strips and be aware of opioids in their supply, so that they're able to keep themselves safe and make sure that folks have Narcan around them, that they're able to reverse an overdose if it happens. They're more likely to overdose because of the lack of tolerance that they have. But there are no Narcan-resistant opioids that are going around New Hampshire. There hasn't been a naloxone-resistant opioid found anywhere. But sometimes it does take a little bit more naloxone to reverse an overdose, depending on how much and when that person took the opioid. Nationwide, where other states have drug checking services, They were able to identify in like the summer of 2024 this year. There was a mystery substance that was floating around across the United States, and it was essentially an additive to like Febreze, like aerosols. So it was like a plastic chemical that was, we think, might have been intentionally put into the drug supply because they thought that it would cause a reaction and create a different kind of drug and a different kind of psychoactive effect. But we have no 100% clarity on that. Luckily, the uptick in that substance has gone down, but it's always a worry to find some new industrial chemical in the drug supply. Because when we're talking about specifically how people like inject with a industrial chemical, it can cause very severe wounds. It can cause, you know, folks were having like bleeding of the lungs and coughing fits. It was not good across the United States. There has been an uptick in benzodiazepines in the opioid supply. It's just one of those things to give the opioids legs, make it feel longer, more faster acting. Um, Benzodiazepines are a little bit easier to get a hold of, still incredibly difficult, but it's just one more thing that they're mixing into the supply. So that's another thing to be concerned about, especially when we're looking to access treatment. And then overall, there has been a really big switch from IV use, injection use, to smoking. There has been harm reduction programs all over that have added things to their harm reduction menus, like we spoke about earlier, like methamphetamine pipes. There's also things like foil that it's a specific harm reduction foil that people are able to smoke off of. There are different types of pipes to smoke, like there's a long stem would be specifically for crack. There's something called a hammer pipe, which kind of just looks like a hammer. And folks are really able to use anything out of that. And when folks are able to smoke over inject, it gives them less of a potency to their drug, so it does decrease their overdose risk. These are some awesome sites to look into. Um, if you're looking to nerd out about any kind of drug specifically or the drug supply around the world in the United States, Opioid Data Lab is from University of Chapel Hill. Drugs Data is an independent forum put on by the folks at Arrowhead, which Arrowhead is like a drug journal for every kind of experience, whether it be one substance or polysubstance, but they're all really great sources to check out, and you can get lost in them for hours. So finally, our naloxone update. Um, So we're not going to go over administration of intranasal naloxone. If that's something that you are looking for, feel free to reach out to me, and I would love to teach you myself or have anyone from my staff teach you how to use intranasal naloxone because it is so easy. I am teaching my 2-year-old what it is and how to use it. Um, so, but very important on the opioid antagonist front is there has been new medications that have come onto the market that are not the best option for people who use opioids consistently. So what we have here is you can see Narcan. That's a 4 milligram naloxone, and when you administer that to somebody, it has a 30 to 90-minute half-life. So it sits in your receptor, your opioid receptor, for about that long, depending on the potency and the amount you used. Um, but in most cases, for somebody who is not a novice opioid user, who's having an opioid overdose, 30 to 90 minutes is the typical amount of time. And then, of course, you have right next to that the IM or intramuscular zero point 0.2 milligram standard dose of naloxone. This is really like the gold standard for people who are consistently using opioids, because no one has ever passed from a lack of naloxone. The only thing naloxone is doing is giving you the ability to breathe back. It is removing those opioids off of the receptors, and it is not suppressing your ability to breathe anymore. Um, when folks are given something like Cloxato, an 8 milligram naloxone, which has a 2 to 3 hour half-life, that's about an estimate, it's really unnecessary. It's unnecessary to give somebody who uses opioids consistently that much naloxone, um, because what it can do is it can put you into precipitated withdrawal for even longer. The thing about naloxone is the 30 to 90-minute half-life. That's just enough time for medical intervention, or that's just enough time to keep someone stimulated, get them up and walking, trying to like keep them awake so that they're not nodding out. But when they have 2 to 3 hours waiting in between being given Cloxato and being in precipitated withdrawal, that is 2 to 3 hours that they have to live through incredible, intense pain with no relief. And a lot of the time, folks are in such great pain from precipitated withdrawal that they are more likely to go out and use incredible amounts of opioids to make it go away. And a lot of the time, because they've been given something that just hurt them, they will make sure no one is around them to intervene because they don't want to go through that pain again. So this means we lose people. This means that people die in severe pain from withdrawal when we could have given them their ability to breathe back with a simple IM 2.2 milligram dose, kept them awake, stayed with them, intervened if we needed to afterwards. But they're able to maybe go get a little bit more, use a tiny bit, just so they're not sick. If folks are not accessing SUD treatment because of the fear and pain of withdrawal, then that has to tell us something. Um, and then finally, something that people who use drugs do not want. This is not advocated by people who use drugs. This is not advocated for people who are advocating for people who use drugs. And the science is not there for the proof that it works better or it works longer or it works for some mystery made up naloxone resistant opioid. Because, like we said before, those are not real. And it's called Opvee. It's a completely different opioid antagonist, and it's called nalmefene. Now, nalmefene has an 11-hour half-life. So you are someone who has used opioids for a really long time. You have an overdose, and you're given Opvee. And with that, you have 11 hours of hell to live through. There have been individuals who have hurt themselves. There have been individuals who have ended their lives. And there are individuals that have said, I would rather pass from an overdose than ever be given 11 hours of hell. And I think that's really important. We, I think that the differences between nalmefene and naloxone, the only thing between them is how they impact people who use drugs negatively. Um, we lose people when we lack compassion, when we lack accurate scientific response. There was recently a compassionate overdose response summit where a whole bunch of professionals in harm reduction, in medicine, um, in addiction treatment came together and decided no one, naloxone, no one wants Opvee, no one wants Cloxato. If it's not broken, don't fix it. It doesn't need to be fixed. Um, Narcan works perfectly fine to reverse an overdose. And in most cases, you only really need one dose of naloxone. I can include the Compassionate Overdose Response Summit report in any kind of notes, but it is 100% worth the read, and it's a beautiful connection between providers and advocates. So this is my favorite little macaroni noodle example of what happens when you are given an opioid antagonist when you are having an opioid overdose. It essentially kicks those opioids right off the receptors and it sits in the receptor for whatever the half-life may be. If a person is unresponsive, they may just be in a deep sleep. It's called a pre-acute overdose, but it's so important when you are responding to an overdose to give someone naloxone when it's appropriate. Um, you know, when you see someone on the street, they look like they may be passed out. That is not an appropriate time to just stick Narcan up their nose. What we need to do is we need to try and stimulate them. Sometimes people are just a little too high. That's the plain and simple. They're a little too high and they need to be woken up. Kind of sternum rubs work really good for that. Just trying to keep that person engaged and alert so that they're able to stay with you. But if they are unresponsive, but they are breathing, we do not need to give them naloxone. In some supervised consumption sites, overdose prevention sites, they don't even give folks naloxone when they're pre-acute in their overdose. They give them oxygen because that's what you're missing. Your brain is missing oxygen. It's so important to wait 5 minutes in between doses of nasal naloxone and intramuscular naloxone. Wait for it to kick in. You don't need to pump that person full of naloxone. Um, if they are unconscious still, but their breathing comes back, then good. They do not need any more naloxone. They have been given the dose that is fine for them. What we hope happens is they regain consciousness, their breathing changes, and EMS arrives. Any of these things happening can be forward momentum into getting that person better. They regain consciousness. Please don't expect them to jump up and punch you in the face. That is, those are some myths to keep people from reversing overdoses when they need to be reversed. Or we hope their breathing changes. Maybe they're still unconscious, but their breathing has changed. Or EMS arrives and they're able to take over on chest compressions, CPR, naloxone. Maybe if they have another drug in their system, EMS is able to administer what they need to make sure that person is safe and taken care of. But if their breathing doesn't improve, you need to breathe for them. Oxygen is the most important part when we're talking about overdose response. If you, for some reason, do not have naloxone on you, and if you're a good harm reductionist, you should always carry it with you. If you don't have it on you, breathe for that person. Always have a CPR shield in your purse, in your car, on your keys. I have a naloxone and a CPR shield tied to my keys, so no matter what happens, I am ready to intervene if somebody is lacking oxygen. And if they are lacking oxygen, it could be for an entire other medical reason other than overdose. But it's important to have CPR shields to keep their wet and gushy on them and your wet and gushy on you. Breath is life. No one has ever died from too little naloxone. We need to focus on oxygen. I think as harm reductionists and some public health folks have moved away from the basics. We need to go back to the basics. We need to remember oxygen is what the person is missing. That's what we need to give them. This is, of course, the recovery position. So if somebody is unconscious, but they are breathing again, we make sure to put them in the recovery position. So in case they throw up, they don't aspirate, and they're better taken care of in this position and they're safe. So intramuscular naloxone administration. So intramuscular naloxone administration may seem difficult, but I promise it is just as easy as intranasal. So you're going to have a kit, hopefully from the Harm Reduction Coalition, has everything you need in it. On it, it will even have the directions for how to do it with pictures. So what you would do is you would uncap your syringe, you would pull out the plunger before it stops so that the tank is full of air. Um, you take off the orange cap. You cannot stick a needle through the orange cap, so make sure to take that off. And then you're going to stick it into the bottle, into the vial of IM naloxone that you have received through the rubber stopper. You're going to, of course, push the plunger down so all the air goes into the vial, and then you will feel the plunger start to come back up, and it will come back up with the liquid. The reason you put the air in is to make sure all the bubbles are out. We don't want anything in our syringe that's going to inject air into somebody. But it also helps the plunger to come back up, so you'll feel it come out of the base of the syringe, and then from there you've drawn up your dose of naloxone. So make sure that there's no air in the bottom. You can squirt out a couple drops. Don't worry, it will still be enough to be potent. Um, and then we're going to take the syringe and we're going to put it down directly, like in this photo, into a muscle, like a shoulder. If we're thinking about how we get flu shots, how do those usually happen? You pinch, go in. In an emergency, it can go through clothes. It can go in the front of the thigh. It can go through the shirt. So, and then of course, pushing down the plunger to empty out the syringe because we want to get to the muscle. Of course, it's okay to inject through clothing in an emergency. Um, so that's how we administer IM naloxone. But after all this happens, what happens to the person who had the overdose? We need to give them some aftercare as the person responding to this emergency, or the clinician, or the provider, or the harm reduction specialist. So we call this welcoming someone back to consciousness. I think it's so important. Start with clear the space as much as physically possible. And if this person returns to consciousness, they're waking up. Nobody wants to wake up from a horrific traumatic event like an overdose and see a whole bunch of looky-loos around them. So everyone needs to go away. You can stay there, and you need to tell them exactly what happened. So you need to tell them, hi. I always try to start something with, hey, friend, you overdosed. I made sure that you needed naloxone, so I gave you some Narcan. I called 911. Inform them if you called 911. And this is not the time for intervention. This is not the time to tell them about their treatment options. This is the time to be there with them and sit with them in their humanity. Um, Treat that person with dignity and respect as you would any person. Remind them that they're safe with you and you're going to be with them if you can. And if they choose to leave before EMS arrives, recognize that people make decisions based on their circumstances, and you don't have control over that. But be sure to remind them that, hey, naloxone can wear off in about 30 to 90 minutes after I gave it to you. If you have more naloxone, give it to them and say, please give this to a friend. Please stay with a friend. I just want to make sure you're taken care of. Um, a lot of the time when you are responding to overdose compassionately, folks will stay for EMS, especially if they have an advocate in their corner. And of course, when a person has an opioid overdose and they are not given naloxone or oxygen, their brain has been deprived of oxygen. If your brain is deprived of oxygen for 3 minutes or more, there is a huge chance of a sustained brain injury, and that can affect you long term. The more overdoses you have, the more likely you are to have a sustained brain injury. This is called anoxic brain injury. Um, and not only can it affect you in your everyday life, but it can affect you in your overall substance use disorder treatment and your recovery. Um, it's incredibly hard to get better when you have something as severe as a brain injury. So across New Hampshire, we got lots of SSPs. You can see them all here, and this QR code will take you to our website. And feel free to scroll around our website, check out all the SSPs around New Hampshire, maybe find some resources, book a training with yours truly, book our mobile van. There's lots of different things on there, and our website's beautiful because our director of marketing is just so talented. And that is that. I have absolutely loved speaking with you for this Harm Reduction 102 and Naloxone update. I, of course, have my email here. If there are any questions at all, feel free to reach out to me. I'd love to chat with you about anything harm reduction related. And I'd love to hear your perspective on harm reduction in New Hampshire and this training overall.